get me to where you started on surgical service. How did you get involved and decide this is something I want to do for the service of others, is go and do surgical cases?
So that was an interesting story. This is in the making about 13, 14 years now. So obviously it was before 2007, it says on my website. Our first trip was to Morocco. But how it all started was kind of a funny story. A very good friend of mine who was Colleen, she was Colleen Hakimi, and at the time she's Colleen Brennan now. She was a pediatric oncology nurse at Hackensack Hospital. Good friend of mine, and my other friend, Kathy O'Hara, who used to be a trauma surgeon at Hackensack, but now is out in Long Island. Colleen was a equestrian like myself. We both rode horses, and she fell off and broke her coccyx. So while we were going into the hospital and visiting her and making fun of her for breaking her butt, we were trying to keep her spirits up, and we were all in the room with her, and a bunch of us started saying, you know what I've always wanted to do? I was about 5 to 7 years in my practice, always wanted to go on a mission trip. And she said, oh my God, that's what I've always wanted to do. And everyone in the room said, oh my God, that's what I've wanted to do. So we started thinking about it, and she's very good at organizing. In fact, she's gone back and gotten her degree in public medicine, and she's gonna go into, I'm sure, do great things with public service and international medicine. But when we started this, we met some people who ran an organization out in Long Island called Operation International, and they had been running missions for many years, and they were interested in sort of branching out and maybe getting a second team together to do the same thing. So we sat down with them, and obviously there's a lot involved. Our first mission was like on a wing and a prayer. We literally packed everything up in my basement the night before till 3 o'clock in the morning. We gathered a lot of expired equipment when that was not problematic to bring that to other countries. It is now, but so many things in the United States expire that don't need to expire. Tongue depressors. Yep. and gauze pads, and you can't bring those anymore because the other countries have all kind of caught on to the fact that an expiration date is supposed to mean something, and they all check now. But back then we were literally just going into all the operating rooms and say, give us all the stuff you don't want, and throwing it together into suitcases. We recruited Dr. Victor Valda. I don't know if you ever knew him. He was the pediatric surgeon at Hackensack Hospital, and we had a very wonderful pediatric orthopedic surgeon named Jim Tucci, who was up in Westchester. And it was the three of us, and then we amassed a whole team, mostly from Hackensack. It was really just people we knew, anesthesiologists we knew. Hey, you want to go on a mission trip? And we did it. We went to this tiny little clinic in Morocco, and I would be willing to say that it was a bunch of really, really, really smart, motivated people that, if not for that, we would have made a big mess of it. And these people, the nurses, the OR nurses, the recovery room nurses, the pediatricians that we brought with us, they were just a bunch of incredibly dedicated, really, really, really intelligent people. And we made it work. We could set this thing up in a tent if we needed to. And we had some portable anesthesia machines, some spectacular pediatric anesthesiologists who could, put these tiny little, 2-pound kids to sleep without any pediatric care leading up to that point, get them all through, get them out alive. And we made it through the first mission. And then when we got back after the first mission, we took care of, I think, 85 surgeries that first mission.
Wow.
Yeah. And all orthopedic surgeon, plastic surgery, and pediatric surgery. We did, and then we had someone who went and did site visits every year. Colleen herself would go and do site visits, visit a place, get the organization. We would fundraise, and it's basically just literally a homegrown group where we do all our own fundraising. We do the fundraiser. I live on a horse farm. Don't know if I mentioned that before, but we do all of our fundraising on our horse farm in October, usually when we're not having a pandemic. We get the money from our yearly fundraiser, and we put that into wherever we're going next. And the group has certainly grown in leaps and bounds. We have gotten smarter. It is much more difficult to do pediatric surgery or to do general surgery. We are a pediatric team exclusively, so we really only do children. We bring pediatricians and pediatric anesthesiologists. But we have discovered over time that doing ENT can be fraught with problems when you're in some of these third world places where they don't have ventilators, if you have airway issues. So we've done ENT and then really sort of not been happy that are out. We've never had a death, fortunately, but we don't ever want to have one. And we found that ENT was very scary to do, even more so than doing cleft palates, for airway issues for sure. And some of the general surgery, we've taken general surgery a few times and done pediatric surgery. I think from the standpoint of really being able to help people and have them be able to recover, have the children be able to recover in the time that you're there. It's much harder to do general surgery. I think it's better for a pediatric surgeon to go to a university hospital and recruit in patients and work with the doctors that are there. It's much easier for orthopedics and for plastics for us to kind of come in, do the job, get them recovered and leave, and have much less skilled follow-up. We'll always have someone in country that can change casting and follow up for surgical complications and things like that. But so we've mostly narrowed it down to being plastic surgery and pediatric orthopedic surgery for the last several years.
How did you identify these locations? So you've been to Ghana or Kenya, Egypt, Peru, Morocco. You've been everywhere.
Jamaica. Guatemala. It goes. Egypt. Egypt was a really interesting trip. We were the only Americans, the people in that area had ever seen or imagined. All the women had burqas, and there was a truck, a pickup truck behind us filled with men with AR-15s. That their job was to protect us when we were driving from the hotel to the hospital every day. We worked at a university hospital in Ben Ha, Egypt. It was unbelievable. They cried when we left. They had no idea what I was, a female surgeon. That was like so bizarre. And one of our greatest pictures from all of our mission trips is, none of the male surgeons at the hospital would talk to me until we get there usually on a Saturday. We start operating on a Monday. And the joke is that nobody would talk to me until Wednesday. And then sort of little by little, they were kind of seeing the patients come out of the operating room and seeing what they looked like, and that they were getting fixed. And one by one, they started to kind of come into the operating room and look over my shoulder. And there's a picture of me in the middle of all these men. There's a little tiny baby head, and I'm doing, I forget whether it was a cleft palate or a cleft lip, or it was a redo something. And there are about 14 male surgeons, none of whom are wearing gowns or gloves or anything. They're all standing like on top of me, all looking down at the patient, at what I'm doing, and then just me, operating. And it's a great picture because they overcame, their ignorance, you know, and they really were interested, and they really wanted to learn, and it was really fascinating. It was really fascinating.
Cool.
I think the best thing I did in Egypt, and this is a little bit maybe too technical, but I think the best thing I did in Egypt was teach those guys not to operate on kids, because they would see a problem and they would fix it, you know, and then the kid would come back with a fistula in his cleft palate. You know, they'd fix it when the kid was this big, and then they'd see a fistula in a palate, and they'd go, oh, okay, the book says this is how you close a fistula, and then, you know, they'd wait about a week, and then they'd try to fix the fistula. So I was seeing kids, I was seeing kids who were like, you know, 4 or 5 months old, who had 4, 5, 6 operations already to fix the damage that had been done on the first time. So I was saying, what you got to do is don't operate on them. And they'd say, well, how old do they need to be? And I'd say they need to be this tall. When they're this tall, then you can operate on them again, you know. So one of the things I did in Egypt was mostly teach them when not to operate. That was a really important thing there. But how we find the places to go, really, our organizer, Colleen, gets a place in mind, word of mouth, through the other organization, and goes and does a visit there. She's an amazing person, and she gets to know literally the board of health and the minister of health and the vice president of every country, and everywhere we go, she meets everybody, and gets us an area to go to. We have been trying since we started, in addition to going a different place every year, to start a sustainable project. So we first tried in Kenya. We were in a little tiny place called Kakamega, Kenya, which is in the western side of Kenya on the Uganda side. And we had gone there twice in a row. And by the time we got there for the second time, things are so malleable in those places. You know, you start a program, you start a thing, and all the people who were at the hospital, you go back the next year and all those people are gone, you know. So, and nobody remembers the thing or that you were going to, you know, do something. But we've actually found this site in Ghana where the administrator of the hospital is a very well-educated guy who grew up in Ghana and wanted to help, and, you know, went to one of the most rural places he could find. And whereas he could be administrative of a hospital, certainly in Accra, you know, and be making a regular salary, he chose to stay in this tiny little town in Ghana. And so because of him and our organizer, Colleen Brennan, we've been donating, you know, outfitting operating rooms, and donating, you know, ambulettes, and baby ambulettes, and you know, all kinds of equipment for that hospital, so that when we go back, you know, we try to do as much teaching as we can, and try to elevate the hospital as much as we can. We do a lot of teaching. The recovery nurses love doing a lot of teaching with the nurses that are there. It is interesting. There's no plastic surgeons, you know, there's no plastic surgeons in Ghana. I'm sure if you live in Accra and you want to get a facelift, you could probably do that. But out in the middle of nowhere, you know, a flight and 7-hour drive away, there's no plastic surgeons. So it's hard to do teaching in a place where there are nobody's trained in that manner of speaking. There's a lot of I've found in a lot of these different countries, in all different continents, that there's a lot of general surgery trained, you know, in-country doctors who are wonderful, and they all love orthopedic surgery. So they're all really interested in learning how to do orthopedic surgery, and not too many of them are interested in learning how to fix burns or learning how to fix clefts.
Right.
You know, we did want to differentiate from like Operation Smile and OpKit, you know, those kind of things, Smile Train, in that we didn't want to go to a place and just do clefts. You know, well, we wanted to originally, when we started and we had the pediatric surgeon and the ENT and everybody, we wanted to try to go to a place and take care of as much, you know, surgical issues in children as we possibly could. And again, that sort of did get more narrowed down just because of the logistics and the realities of taking care of those kind of things. But we still wanted to try to do as many different things as possible, which is why, you know, I probably do more burns than clefts actually when we go to those areas.
Right, because there's just so many burn injuries.
There's just so many burning. It's
Yeah.
really, most lay people say, why are there so many burns? I say, well, if you really think about it, you'll figure it out. I mean, these
Right.
people, they do everything with fire.
Yep.
They light, electricity, heat, warmth, burning
Right.
garbage. Everything they do is with fire. There's a lot of
Yeah.
kids. There's not a lot of supervision. There's no real super safe fireplaces. Everything's just out in the open. So the
Right.
burns are everywhere.
Right.
I learned a long time ago not to do any acute burn surgery. I don't do any acute burn surgery because I'm not
Hmm.
changing the course of anybody's life. But it's the long-term scar
Hmm.
contracture
Right.
surgery where I can change a lot of things. I do a lot of latissimus flaps for burn scar contractures. Believe it or not,
Oh, really? Oh,
I
for
get to.
the axillary burn contractures.
For the
Yes.
big axillary burn
Yeah.
contractures, yeah, and if
Yeah.
scapular flaps or fascial flaps aren't going to be enough, I have done several latissimus flaps on 4, 5, 6, 7, 8-year-olds. Yeah,
That's awesome.
which is a whole, yeah, and I mean, you put a muscle flap on a contracture and then you discharge them and you don't
Yeah,
worry
they're
about it
fixed. You don't have to
because
worry
they're
about
done.
physical therapy or something like that.
They're
Yeah.
done, and that's if when I'm triaging those cases, if I can find, they all get first. Like the patients I can do a muscle flap on, they all
Right.
go first,
Right.
because those are the things that, like I said, I mean, you can fix it, they could go home.
Right. Now, I always found that as much as these missions help kids, I think their impact also goes way beyond that in the sense the surgeons that you impact, and not just in terms of techniques or learning when to operate or not operate, but also culturally, they're seeing people that are women that are operating. That's a new concept for them. Some concepts are, not that we're trying to impose culture, our cultural values, but it's just a different sense of cultural values. And they're imparting onto us when you travel. I would assume you learn quite a bit that broadens your mind too about what medicine is or what life is.
I think it's absolutely invaluable. And I think if we could take every teenage kid in the United States and send them on a mission trip, I would do that, because it is absolutely the best thing for, especially, I think, kids who grow up in this country and have never seen, just us seeing what they don't have. A really good example from the very first mission trip we did in Morocco. Again, it was this little tiny clinic. We come in, we take over, we do, we don't ask anybody anything, because we're like, okay, we're on a mission, we're doing this, kind of push everybody out of the way. We do, and we do this. And over in the corner, there was, which, by the way, we learned a lot about that. Like, talk to people, get their names, don't push them out of the way. Like, we've learned a lot since our first. We were overly excited on our first mission, but on that mission, there was this wonderful guy, is general surgeon. They basically, in Morocco, they train you, and then they, like, if you want to work for the government, they like give you a clinic, and they give you like $8, and they say, do what you can do. And this guy was wonderful guy, trying to learn everything he could and just do what he could do. But he had this little kind of makeshift emergency room going, and this little girl came in, and she had this, this was like an 8-year-old girl. She had this horrible laceration on her foot, and we were doing our thing, and he was going to close up this laceration. Of course, they don't have any lidocaine, so he's gonna debride this laceration and close it. And it was big, it was a few centimeters long on a little foot, and he was going to do it without any lidocaine. And my nurses from the OR, they came running over to me, and they were like, he's in this little section, and the kid is wide awake, and he's not using lidocaine. And I said, well, he doesn't have any lidocaine. And they were like, well, but we have lidocaine, we can give it to him. And so I went over to him, and I offered him, I can numb that foot up for you. And he looked at me kind of weird, we're fine. The kid's screaming her head off, and he finishes. And I realized later on, after having experienced that whole experience and being there and being immersed in it the whole time, like, he's not going to have lidocaine tomorrow after I leave, and he didn't have lidocaine yesterday before I came. And so me coming in, and especially it was really upsetting to the nurses that had gone and seen him doing it. I mean, they were really upset. You know, they came to me, we have to stop him. We have to stop him from doing this. He's torturing this kid. And I said, you know, it's how they do it. And they don't have any other choices. They're not doing it because they want to torture the kid. They're doing it because it's the only way they can do it. And so whether we give this kid lidocaine or, you know, or tomorrow he's not going to have any more lidocaine. So that was a really interesting thing to me, because there's not a place in the United States you could go where they wouldn't have lidocaine to sew up a laceration. If they didn't have it, they'd get it. You know, I mean, what do you mean you don't have it? Like, that's not acceptable. You know, you'd go get it somewhere. Nobody would ever even conceive of suturing up a kid without any lidocaine. And
I'm not going to comment on U.S. drug shortages, but just keep going.
Yeah.
Okay.
Yeah.
But
Sure.
you're right. You know, you can't impose your values when, and you can't help them unless you help them the way they live.
Yes, absolutely. Right. So you have to really like integrate that, and you have
Right.
to kind of understand
Right.
like what they're doing. I had another great story of a kid who had a radial claw hand, and I actually did a policization on that kid.
Oh, wow.
Yeah, it was after my partner Janet sent me a paper on how to do it. By text message, I think.
Uh-huh.
But anyway, the kid had a syndactyly on the other hand,
Mm-hmm.
and his right hand was a syndactyly, if I remember correctly, and his left hand was this really, you know, really badly deformed hand. And you know, I'm all getting excited and getting ready to do this really interesting case, and I'm getting consent from the mother, you know, and the consents are really, it's a really touch. I mean, they don't understand consent. You know, you start to try to explain to them that there's complications that might happen, and they look at you like, can you fix this? And you're like, yeah,
Right.
sure. And they're like, okay, so then fix it. Like, I don't understand. That's a whole other topic. It's a whole other really
Yes.
interesting topic.
Yeah.
But I started consenting her for the left hand, and she kept pointing to the right hand. No, 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 no. It's this hand. It's this hand. I was like, I don't understand. This hand, you know, is not even functional. This hand is a perfectly functioning hand. That kid could be a surgeon with that syndactyly. I mean, his hand was functioning totally fine. And we kept going back and forth and kept going back and forth. And I learned later, you know, I learned through that whole process that apparently in this area, in this tribal area, you know, the left hand is the dirty hand and the right hand
Right
is the
hand's a
clean
good one.
hand.
Yep.
Yeah, the right hand is a good hand. And she was so concerned that that kid was not going to be able to get a good job and a good life and go to school and all that, because it was the right hand that needed to be perfect. And that was really interesting to me, you know,
Yeah.
because that was nothing that we would ever even think of. And you run into those things all the time where you have to really go with an open mind
Yeah.
and really, you know, pay attention to people when they're talking to you, because it's so interesting. We had a pregnant teenager with a tumor on her jaw when we had the head and neck surgeon, and we had a big team meeting because why we tested her, I don't know. Next time we learned a lesson not to test, but we did a pregnancy test on her, and it was positive. And you know, honest to God, the best thing that could happen to that kid was we hadn't tested her. We really came to the conclusion later on that had we not tested her, you know, it would have been the best thing for all involved. But we did, and you know, of course, her family didn't know, you know, that she was sexually active, and we didn't want to do the surgery because she was in her first trimester. Obviously, she wasn't showing, and we kept trying to explain that anesthesia is very, very, very unsafe, and they were absolutely they didn't understand, absolutely insistent that we do the surgery. And we had this big team meeting, and even members of the team were on absolute opposite sides of this issue.
Mm-hmm.
And we ended up not doing it because my first thing is to do no harm, right?
Mm-hmm.
So we ended up not doing it. It was a benign tumor, not a malignant tumor, and we in the end we decided not to do it. So
wow, that's so interesting.
yeah.
That reflects about all the cultural and differences and in just one situation that,
oh yeah,
and I could
absolutely.
totally see how you could legitimately be on one side or the other side and have a valid argument about what you should do in that situation.
Absolutely, absolutely. There's a
Yeah.
picture of me standing in Kenya in the clinic, and the two hospital administrators had come down to talk to me. They wanted me to take this huge cystic hygroma out of this kid. We didn't have our head and neck surgeon anymore. This 6-month-old kid with this giant cystic hygroma, and I this is the place where they don't have a ventilator.
Oh.
So if the kid had an airway problem, and it was like 2 days before we were set to leave. And if the kid had an airway problem, I was just like, we're going to kill this kid.
Mm-hmm.
They didn't care that we were going to kill the kid. They just
Mm-hmm.
wanted to see how it was done. They'd never seen it before.
Oh, wow.
And so there's a photograph of me, and another great picture. There's a photograph of me standing with my arms crossed like this. And these two guys are like standing over me, and they're pointing at me, and they're hospital administrators from Kakamega, Kenya, and they absolutely did not understand what my resistance to doing this surgery was, because they had never seen it, and they wanted to see it done, and they wanted to see how it could be done. And I was insistent that the kid was too small and the cystic hygroma too big, and we didn't have any way to support the kid's airway after we and our anesthesia machines walked out the door. So and we were at an impasse. And I just, I walked away, of course, and I said, well, you can't make me do it, so I'm leaving. And obviously I didn't do it, but they were very upset with me.
It's the right thing to do for sure.
Mm.
So at this point, both of us, I would say, have finished the first 9 holes of our career.
Yes, for sure.
And we're probably somewhere on the back 9.
Yeah, absolutely.
And when
I might be on the back 3 or 4.
Right. Well, I wanted to give you plenty of latitude in case you wanted to say you were super young. And I think the one thing I have seen with surgeons who are more established is they figure out what they want, they figure out what they want to do, and they have a better sense of their priorities. Time is always more precious. We realize that. So what is it that you now think is important for you in the future to focus on, to do, to accomplish, whatever it is that you think you have?
So I always said, if I won the lottery tomorrow and I didn't have to work anymore, I would stop doing surgery at Hackensack Hospital and just go on mission trips all the time, because that's where my heart is. My wonderful anesthesiologist PJ Mandalay comes on all the mission trips with me, and she's a pediatric anesthesiologist from Hackensack, and she does all these little tiny babies when I'm putting them to sleep. And if the two of us could just team up and just do that all day long, that's what we would do. But obviously that's not going to happen, and so I gotta keep working for a little while longer. It's an interesting question that you ask this now, because obviously Rick and I have just recently taken on a 4th partner for our practice, and obviously as things go, that means that we're sort of moving towards the direction where Janet and Paul, our partners, start doing more of the heavy lifting, and Rick and I start doing less of the heavy lifting in the practice. Paul Throttle, he is our newest partner, who is very interested in doing breast reconstruction. He did a fellowship in microsurgical breast reconstruction. So obviously that was by design, because I am headed in that direction where he will start doing more rather than less. The hard thing for me moving forward in my practice is that, there's sort of 2 parts of my practice. There's the breast reconstruction, and there's everything else. And everything else mostly falls into, cosmetic or breast reduction, insurance-based breast reduction. But pretty much everything else in my practice is sort of cosmetic. I can't do cosmetic surgery all day long. I'll shoot myself. There are really fun things about cosmetic surgery. There are things I love doing. I love doing eyelid surgery. Breast reduction certainly make me happy. I always muse that if I went blind, what surgery could I still do? And I think it would be breast reductions. My quandary right now, and Rick and I, spend a fair amount of time talking about like how we're going to kind of slow down and where we're going to go and what we're going to do. And I'm ready not to work as much. I'm at that point in my career. My kids are all gone. I'm an empty nester. Well, without COVID, I was an empty nester, but my youngest is 24 and works in the city. And so I am definitely at that place in my life where I could certainly see working a few days a week. I can't ever see not working. I can't ever see going and riding my horse or playing golf or doing whatever. I couldn't do that. I'd have to continue working. But so for the overall plan, for me, that really means doing a lot less breast reconstruction. Because breast reconstruction is the thing in my practice. It's like doing trauma surgery. Like I never know when it's going to come up, and my schedule is not really my own as far as that goes. So I'm stuck with whenever the breast surgeons do the surgery, and I have to be there the minute they're finished, because there's a patient on the table that's asleep with an open wound, and so my life has really been circulating around that fact for 22 years, that if I'm doing something else in my office and there are 4 patients waiting for me, but they call me and tell me that Dr. Warden finished her surgery 45 minutes earlier than I thought she was gonna, I just got to drop everything and be there. There's a lot of disgruntled patients in my office. My staff is a wonderful staff because they deal with that literally every day. Disgruntled patients having to be shifted around or moved around because the mastectomy always takes longer or shorter than we thought it was going to. And so obviously, in order to move to that kind of next phase, I'm going to have to do less breast reconstruction. So bringing Paul in was the number one phase of that, and then actually doing less is the other phase of that. That's hard for me to do because I really enjoy doing that surgery, and I enjoy taking care. I guess it's the patients that I enjoy the most, and we get to know each other very well through the whole process, because breast reconstruction is really quite a journey, and there's a lot of sort of emotional impact on people, and a lot you get very entrenched in a lot of people's lives, and that part that'll be hard for me to give that up. I don't know that I'll ever give it up 100%, but that part would be very hard for me to give up. So so I'm kind of in a kind of balancing act at this point. I'm kind of struggling. I know it's going to go, and Paul's going to do more and more of it, and that's going to be the transition, but I don't know when that's going to be or how it's going to work yet.
I think the COVID shutdown sort of gave everyone a preview of what it might be like.
That is true.
To not work so much. And I knew some surgeons that actually enjoyed it quite a bit. They said, wow, I've been running the hamster wheel so hard, and now I was forced to sort of not. Yes. And this and some people, then it gave them some real fear or thought, what do I do once I actually get to that point? Did yes. you feel that way when you were this year?
COVID was really interesting. I did, my husband was still working more than ever because people needed a psychiatrist more than ever. Sure. And so he was working from home. And our practice came to a grinding halt, except for the occasional mastectomy that was still, for cancer that was still going on. For the first time in my life, as I'm sure you're aware, for the first time in my life, for a couple of months, there was day after day after day where I was at home. I mean, that's never happened. It was really interesting in the beginning, because in the beginning, I felt very much, not that I needed to work or that I was missing out on, that I can't sit home, that I can't get out of my head, because I got lots of stuff I can do at home. Like I said, I live on a horse farm. I have hiking right behind my house. I'm an avid hiker. I've got dogs. I have a lot. I paint, I draw, I've got lots. I play the guitar. I have lots of things I can do when I'm home. So I don't have any trouble taking up my time. Like my father from my father's generation he had nothing to do when he retired. Nothing. I mean, all he did was work his whole life, and he didn't have any other interests. And I kept saying, don't worry about me. I got lots to do. But I did immediately after we came home and I was not doing anything and the world was descending into pandemic, feel very responsible for using my talents in a way that not many people were able to. So I did go back to work at Hackensack on one of the COVID floors.
Oh, you did?
Yeah, I did. It wasn't for a long time. It was for a few weeks right in the middle when things were at their worst. And I became a hospitalist. Well, I was working 3 days a week on 4 Strawbridge and taking care of COVID patients. So that was born out of the just feeling really, really restless at home that I can help, and the hospital needs help. And I may not know anything about pulmonology, but I can learn. I'm a quick study, and I learned a lot about pulmonology. I know a lot more about pulmonology now than I did when I started that.
That's awesome.
And so I did. My partner Rick did. Our partner Janet was pregnant at the time, so we left her home in the office and told her to see any of our patients. And the two of us went into the hospital and we worked. And then when things were kind of chilling down and they didn't really need us anymore, we stopped doing that. And then I stayed home. So more to your point, once I started doing that, I think you're right. I think I really got a visual on what it would be like to actually stay home and not get up and go to work every day. And I liked it.
Surprise.
Surprise. I think I suspect that would get old. I
Right.
suspect that would get old. I
Right.
suspect I've always sort of had this feeling that I've been sort of chasing like time off my whole life. You know what I mean?
Yeah.
And what would it, I think once you got over that hump, like once you feel like, okay, this is all there is time off.
Mhm.
I think that would get old pretty quick, but a short amount of time, I think
Right.
it was like a nice sort of reset. It was kind of like, okay, this is where I'm at, and these are the things I like to do, and these are the people I like to talk to, and those are the people I don't like to talk to, and those things make a difference. And it was a very interesting time in all of our lives, I'm
Yeah.
sure, for kind of reassessing all that kind of stuff.
What do you think about the future of plastic surgery now that you look at it? Is it going to get better for plastic surgeons? Worse? The same? Is it bright? Not bright?
Well, I mean, I've already said a couple of times on this podcast that I miss feeling like a real doctor when I go on my mission trips. And so I one of my favorite things about, again, being on the mission trip is like thinking on my feet, being someone who goes, sees a problem, figures out how to make it work, and tries to fix it, and it's not always successful and it's not always perfect. But the trying is what you're doing, right? You're trying. And that gets so bastardized here in the United States with all the legal implications and the lawyers and writing down everything you thought and everything you think they want to hear and everything you even everything you didn't think. You write down everything. You make sure your ass is covered. You make sure that the patient understands everything that maybe they don't want to understand. There's so much involved nowadays with the whole liability issue. I don't see that getting better anytime soon, unfortunately. It's been building and building and building for a long time. It's kind of one of those things you don't sort of see going backwards. I think the younger generation are going to work differently with it, though. It's like the same thing with the computerized, with the computerization. I mean, believe it or not, Rick and I still have paper charts in our office.
Oh my God.
Yes. And whereas I'm a fairly computer savvy person, I mean, in my house, they all come to me to fix a computer. We have just really been loath to go through the hassle of it because it is just so easy to write a note in a chart. It's just so simple. And whereas I see my junior partners, and they've got Epic and they can get on and off and on and off and do whatever it is that they need to do, and they're much more adept at it. And obviously we'll move into that next phase where it's easier for them and they don't mind it. But it is always an extra step away from the patient, right? Like all the liability and all the computer stuff and all that, you're taking more and more and more steps further and further and further away. You're not
Mm-hmm.
looking at the patient when you're talking to them.
Mm-hmm.
You're looking at a computer screen when you're
Mm-hmm.
talking to them. You're getting
Mm-hmm.
further and further away. It's getting further and further from that, that old fashioned idea of like, the white coated doctor going into a room and, feeling around and poking around and talking to a patient.
Mm-hmm.
I think one thing that, hearkening back to the idea of like, how come my practice and Rick's practice has kind of gone along so many years and
Mm-hmm.
there's not a lot of issues. I think one of our main things when we take care of patients is, like listening to patients. I get so many patients who come and they want a breast reduction. They've been to 4 different consults and they say, oh my God, you're the first person who actually asked me like what it is that I want. You know what I mean? Just talking to people like they're people, is such an important thing for physicians to do. And I think we're losing that. We're losing it because we're getting so many barriers between us and the patients. And that's too bad. It's not all horrible though. I'm not like a super pessimist. I think that my partners who are wonderful, wonderful, caring, empathetic people, and wonderful physicians, I think that they care about that stuff too. I don't think that it has made them uncaring doctors. And I think they'll learn how to deal with that other stuff, probably better than I did because it was new when I did it. And
Right.
we're just sort of on that cusp of, I think, things, changing very dramatically. And so it's always hardest for the people who were kind of in the middle of it and remember the way it used to be. And, it's not a change for you if it's been that way
Always that
ever
way.
since
Yeah.
you started. Yeah. So I'm not super pessimistic. I think they'll figure it out, but,
I hear echoes of Lloyd Hoffman in the personal care and connection with
yes.
patients.
Yes,
I
no
hear that in you.
question.
I hear, the fact that things are going to change, and but trying to maintain that is hard.
Yeah.
I just
Yeah.
went through I just revamped all the paperwork that patients have to sign when they come in for a new patient.
Right.
It's amazing how many papers
It's horrible.
that they have to sign, that it's absolutely
Onerous.
crazy. It
Yes.
is. I think that you're right. The new generation will be much more facile about maneuvering around those issues.
Yes, I think so.
And I think patients expect it. I will tell you that when I try calling patients, I never get them, but when I text them, I get them right away. It's
Yes. Yes.
so the
That is
whole
certainly, I'm a big texter. I
right.
love texting. I'm all
Right.
about the texting.
So I think the means of communication, the manner in which we do it, you're right. How do we maintain connections with our patients?
Right.
I think
Right.
that's super important.
I do want to mention a little bit of a segue, but along the same lines, you're talking about the future of plastic surgery. I do worry with the training of medical students and of residents that when back when we did it, the idea was you went to general surgery, then you decided what you wanted to do, you went to plastic surgery, and there's definitely some advantages to having integrated programs where people are getting a much broader scope of other subjects like orthopedic surgery and head and neck surgery, and they're getting into plastic surgery earlier than they were before. It wasn't just all condensed into this last 2 or 3 years. But my concern about the way that training is going, especially now with seeing the new Hackensack Medical School and the way that they're getting their surgical training in the student years, they're seeing so little actual plastic surgery. And when I mean plastic surgery, I mean, reconstructive, complex surgery. I learned about plastic surgery through learning about the complex reconstructive stuff. And everybody knew that when you became a cosmetic surgeon, it was after years of having been a reconstructive surgeon, and then you kind of sort of skipped into retirement and started doing, eyelids and facelifts and things like that. I'll never forget the time that I asked a third year medical student what he wanted to do. And he said he wanted to be a cosmetic surgeon, you know, wanted to inject Botox for the rest of his life. And I was just
Oh my
like,
God.
I don't know how to respond to that. You know, why'd you go to medical school? Like, you know, like that's horrible.
I agree 1,000%. I think there are a lot of people that think they'll just come out and have a TikTok account and they're going to do just fine opening up a cosmetic surgery practice. And it was funny. I was just talking. We just did. We talked about buccal fat excision on an episode with my two former co-residents, and we talked about how all of us learned not to F around with Stenson's duct because all of us had seen some slash to the face
Some
where we
trauma,
had,
some
yeah,
car
where we
accident.
identified it. We had to tie a silastic tube or whatever in or fix it in some way. And once you know the anatomy of the face, it's a very simple operation, the buccal fat excision, but it's, if you don't have that sort of experience, that extra depth of knowledge or layer of knowledge,
Yes.
makes all the difference in the world. And that's for a simple operation. Once you start talking about real stuff, now, all the things you learned as a reconstructive surgeon, you're learning by mistake as a cosmetic surgeon out in practice.
Yes. Yes. And, you know, I mean, look, think about just the world in general. When we were in school and when we were in our early residency or in medical school, you know, what did you know about plastic surgery? What, you know, back in the 80s or the 90s or the early 2000s, you know, like it wasn't everywhere, you know, you didn't. So you have these young students now who look around and they, you know, they go, I want to, you know, be the Kardashians' doctor.
Right.
You know, I want to be that person. And I think when I was in medical school, you know, we all knew that there was cosmetic surgery out there, but it wasn't so in your face and it wasn't so front and center.
Right.
You know, how you became the person who does that surgery was very, very different then. Yeah. So it's a whole paradigm shift. You know, I know there are lots of kids, I think now, who are students who don't even really know that in order to do a breast augmentation, you know, you have to do a plastic surgery residency and what's all entailed in that, not just learning how to do a breast augmentation. You know, it's very different.
Well, hopefully the pendulum will swing a little bit the other way too at some point. We'll see.
Well, maybe you know, maybe the COVID epidemic will get people back to, you know, thinking about what's really important. Although I do have to say my practice is cranking right now because
Busier than ever.
Yes, busier than ever.
The Zoom boom. Yep.
Yes, everybody wants to just have something done. And now's a good time because they don't have to go into work.
That's right. They're just recovering
they
at home.
can recover. I know it's been really crazy. So,
Yeah.
you know, I'm not going to sniff at that, but
we'll see what happens.
Yeah.
Well,
yeah.
Stephanie, it's been wonderful talking to you. I really appreciate it.
My pleasure.
I wish you the best of luck for both your charitable efforts, for your career,
Thank you.
for everything else that's going on. And I think there's going to be a lot of value for people just to hear your life experience, just a little short bit of it. And hopefully people will take something away from it because I certainly did.
Well, thank you. Like I said in my email, I don't know how you have the time for all of this because it's amazing that you do it. So it's really interesting that you decided to do it, and really great, I think.
It's really fun. Thanks again, Steph.
All right. Thank you.
Okay.
Bye-bye.
Bye.